Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of my clients. And the question in last week's episode was, Dad has ICU psychosis and ICU delirium after 5 weeks, ventilated with tracheostomy. How can he get back to normal? You can check out last week's question by clicking on the link below this video. In this week's episode of Your Questions Answered, I want to continue answering the next question regarding James and Christine's dad in ICU who's had a hemorrhagic stroke. James and Christine's dad had a brain decompression where they evacuated a large bleed from his brain after the hemorrhagic stroke. And their dad also underwent a craniectomy, which is a partial removal of the skull to decrease the brain pressures after the bleed. James and his sister Christine were getting their dad in one of the best hospitals in the United States, the Cleveland Clinic in Ohio. In the meantime, their dad was getting a tracheostomy because he couldn't be weaned off the ventilator and the breathing tube. He also had a PEG tube for feeding inserted. He also had ongoing seizures due to the stroke, and his anti-seizure medications needed to be optimized so he could quote-unquote wake up and progress to neurology rehab. In today's one-on-one consulting and advocacy sessions with James and his sister Christine, we look again at some setbacks their dad is currently going through. He had to be put back on the ventilator due to a pneumonia, and he also ended up with a central line, also known as CVC, and arterial line again. In the meantime, he has come off the ventilator but still has the tracheostomy after over 5 weeks in ICU. This series of one-on-one consulting and advocacy is a real testimony for getting advice, run with it, and get results. If you want to avoid LTAC and a nursing home for your loved one, you need to read or watch all of the consulting and advocacy sessions with James and Christine, because it's a real testimony how to get results. So in today's episode of Your Questions Answered, again, I answer another series of questions from James and his sister Christine, and they're all excerpts again from various one-on-one phone and email consulting and advocacy sessions with me. And the topic this week is it best for my dad to go from ICU to step down, or should he be going to rehabilitation straight away? You can also read or watch previous episodes of these series of one-on-one consulting and advocacy sessions with James and Christine by clicking on the relevant links below this video. And if you are watching this on YouTube, just click on the links. Click on the link below this video. That'll get you to our website where you can access all the other episodes. So let's dive right into James and Christine's questions. So James says, thanks Patrick, good advice in your last email. Why do you suppose neurosurgery is saying one thing and the epilepsy team is saying another thing? This is very frustrating because it's a form of neglect. They have neglected to manage my dad's seizures, and they have neglected to give him physical therapy. Physical therapy says he keeps sliding out of the chair, so they sat him on the side of the bed today for 25 minutes. That's simply not enough time. Do you have any suggestions on how to get him more physical therapy? Many thanks, from James. So here's my response. Hi James, I think it'll be very important to find out who is the primary decision maker now. There must be either a doctor or a specialty he has been admitted under. They will be the one calling the shots. Maybe the epilepsy team wants to get the medication sorted before moving on, which I think is a good sign. And maybe the neurosurgery team wants the discharge because of potential bed blocks, especially if the neurosurgery is the parent team. I agree that if they are not communicating, that this could well be neglectful. On the other hand, as I have said right from the beginning, your dad is on a long road to recovery with an uncertain outcome. Therefore, always keep checking your as well as their level of frustration. Especially with the brain being so unpredictable, there will be a lot of frustration and uncertainty that needs to be managed. I know this is easier said than done, therefore take one day at the time. Even though epilepsy and neurosurgery are related specialties, they are two separate teams and they may or may not work well together. Physical therapy is certainly challenging and it usually works well if the nurses are involved as well. With your dad now in step down, he probably has one nurse looking after 2, 3, or even 4 patients on a shift as opposed to one-on-one nursing in intensive care. They will need to continue doing physical therapy daily, and sitting him on the edge of the bed is good. If he's sliding off the chair, he may well be considered a high falls risk, and it could well limit the time he may be able to spend in a chair. Recovery with a brain injury or stroke will happen over time and will take a lot of rehabilitation, nurturing patients' persistence, and most of all, a positive environment. Stay positive yourself and try and embrace that your dad's recovery is a process and not an event. This makes timelines impossible to predict at this stage. It's a puzzle where many things have to align for him to move forward. He's still only in step down, meaning he's in between ICU and the hospital ward. It also means he's not ready to be discharged yet to a hospital ward if he's at risk of having seizures. Many thanks from Patrick. So here's James' response. Hi Patrick, more great advice. Hospital's still very insistent on us getting out. However, the seizure team has now agreed to drop my father's dose of Keppra from 3,500 milligrams to 0 at 500 milligrams increments per day. He's still on the Dilantin and the other medication, zonisamide. My question to you and my concern is, are they weaning him off the Keppra too fast? I believe his cognition seems to be better. Even with a smaller dose, he was able to say my sister's name today. However, I don't want him to have a setback and have a seizure because our days in the hospital apparently are numbered, and I don't believe once we leave the stuff is going to be that helpful in managing his medication. Also, we are probably going to take him to Chicago for a very aggressive rehabilitation hospital with just the flap. I feel like my father is almost optimized, however, we may be 1 week too early. Please let me know your thoughts on all of the above in writing so I can refer back to it in my notes. Thank you, from James. Here is my response. Hi James. No, I don't think they wean him off the Keppra too quickly. Weaning Keppra sounds good to me as long as Dilantin and the other drug, zonisamide, is being given. They need to wean now while he's still in hospital and monitored by an epilepsy team. Setbacks may still happen, remember, 2 steps forward, 1 step back. They need to take measured steps now to optimize for rehab wherever it will take place. Here is also a quick summary of what we discussed over the phone. Try and find out if they want to keep the tracheostomy for the purpose of ventilating your dad during the surgery for putting the cranioplasty back on, or if they think it can be removed soon. Try and speak to Medicare and find out what his entitlements really are. Remind them that moving around different facilities or hospitals over the next few weeks is not going to be conducive for his recovery. Consistency of care is going to be really important, especially with the ongoing confusion and delirium. Also, remind them that your dad mentioned he does not want to be moved yet. You could also argue that seizure activity needs to be monitored for a few more days after he has come off the Keppra completely. Having another seizure could set back your dad significantly and nobody would want that. LTAC or long-term acute care is not equipped to be closely monitoring any seizure activity. Overall, I do believe your dad is making progress and I believe he's coming very close to be leaving step down soon, and that's a good sign. Moving him to LTAC or long-term acute care, then back to hospital for the surgery, and then potentially going to Chicago sounds very stressful. And it's not the type of stress your dad might need at this phase of his recovery. This is the level you should argue on. Furthermore, I'm a big believer that everything in life is negotiable, and I think you should put your best foot forward and see how far you can go with arguing on that level. Clinically, I can't see anything life-threatening that may warrant to stay in step down. However, arguing on all the other levels we discussed is definitely worth a try. I hope that helps, James. Let me know what else you need or if you need further clarification of any of the points we discussed. Now, and if you are watching this, you can, and if you want one-on-one consulting and advocacy with me, you can either select from the options on the top of the website, or you can just book a free 15-minute free consultation with me over the phone, and then I can advise you from there. You can book a free appointment on the top of the website where it says schedule free appointment. So James continues and he's writing back. Hi Patrick, great advice again, thank you very much. And again, thanks for all the information. I pleaded my case with the doctor today and I believe I will be able to keep him in the hospital as opposed to going to LTAC based on your explanation of continuity of care. You're not just the ICU expert. I believe you understand the healthcare system very well, and I value your judgment. Touch base with you soon. And thank you again from James. So here is my response. Hi James, that's great. Well done. Thank you for letting me know. If you found a strategy that works, keep doing more of it and not less. And also thank you again, James, for your kind words. I tend to know which buttons need to be pushed to get to where you want to go. It also helps that you are not timid to implement. You are your dad's best advocate. No matter my advice, you are the implementer, and many families in intensive care are often too timid and intimidated to implement. So give yourself a pat on your back for implementing. Very happy to help you wherever I can. Please also see a quick summary from our conversation here. Again, try and keep buying time in the hospital if you can. Talk to patient affairs and keep arguing on the level of patient care, continuity, and also the stresses of moving him to different facilities in short periods of times. Your dad will need consistency of care and you don't want to jeopardize any recovery he has already made. Weigh up the pros and cons of going to Chicago versus going home. Home is not impossible, but he may benefit from a rehab facility first. Getting him to rehab within the Cleveland Clinic might be dependent on the availability of skilled nursing staff who have the skills and expertise to manage his tracheostomy. Getting the cranioplasty done now and then move to rehab to Chicago would eliminate a transfer back to Cleveland. As I said before, I don't think moving him around from hospital to hospital will benefit your dad, and it could be very stressful to do so. Your dad is still in a very vulnerable position, keep reminding them. Their one-size-fits-all approach to moving patients along their pathways might fail in your dad's situation because of him coming from interstate and having limited family support around him. Their approach needs to be more tailored towards your and your dad's individual situation. I would really suggest to get the cranioplasty done soon. Then you are free to move either back home or to Chicago. I hope that helps. Any questions, please let me know. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power, and influence quickly whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision making fast whilst your loved one is critically ill in intensive care. Your free instant impact report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free instant impact report now by entering your email below. In your free instant impact report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions. Discover the many competing interests in intensive care and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind-the-scenes insight so that you know and understand what is really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also have a look at our blog section for more tips and strategies, or simply send me an email to support@intensivecare.com with your questions. Or you can call me. Find international phone numbers on the top of the website. Also, check out our ebook section, and you can also get one-on-one consulting and advocacy with me via Skype, over the phone, or via email by clicking on the relevant tabs on the top of the website. This is Patrick Hutzel from intensivecare.com, and I'll see you again next week in another update.